So, hello guys, my name is Gadwin Kendall Napalos Patazo, and I'm here today to give the report all about nursing care of a woman and family during the first 24 hours after birth. So, a woman remains in the birthing room for at least the first hour after birth, so she has time to become acquainted with her new baby and to provide for careful health care team observation. After this initial hour, teach perineal care and encourage a woman to shower. She then remain in the room as postpartum patient or is transferred to a separate postpartum room. The most dangerous are in childbearing. The first hour after birth has passed. Hemorrhage is still a possibility for the first 2 or 3 days after birth until the myometrial vessel have sclerosed. One of the worries for a woman giving birth at home is that she will not appreciate how dangerous a time this is, with attention focused more on the newborn than on her. Postpartum hemorrhage could occur in the hospital. Various healthcare personnel may be involved in caring for a woman. Be sure all members of the healthcare team are knowledgeable about this danger. So now we're going to proceed to the assessment. Assessment of a postpartum woman includes history, physical examination, and analysis of laboratory findings. So going to the history or the health history, the technical aspect of a woman's pregnancy, labor, and birth can be learned from her pregnancy, labor, and birth charts. Most of this information is best obtained from a woman herself. However, because this supplies not only information on the events of her pregnancy and labor, but also her emotions and impressions about them. If you previously cared for a woman during labor and birth and gained this information, then it is unnecessary to do so again. Now proceeding to the family profile. Information for a family profile includes age, support person, other children, type of housing and community setting, occupation, education level, and socio-economical level, or the information necessary to evaluate the impact a new child will have on the woman and her family. This information also lays a foundation for teaching self-care and child care specific to the woman's knowledge level and needs. So why do we need to take note about the family profile? So we need to take note about the family profile to give the necessary nursing care and to give fundamental teaching to the woman based on her knowledge level and needs. So we're getting this family profile para makasabot kita kung impact what is the impact of the new child to the family and to the woman, para if makahatag ta og proper information and advices to the family and to the woman how to adjust or how to handle the new child. Okay? So next, we're going to proceed to the pregnancy history. Pregnancy history or the information for a pregnancy history includes para and gravidez status and the reason for any discrepancy, expected date of birth, whether the pregnancy was planned, and any problem or complications such as spotting or pregnancy-induced hypertension that occurred. This information helps you to gauge a woman's potential for bonding because an unplanned pregnancy or complications arising during pregnancy can interfere greatly with the bonding. So we need to get the pregnancy history of the patient to understand if there are any complication or if the pregnancy is unplanned or if it is planned or how many pregnancy the woman have. Kay by this information we can understand or we can give proper education or proper knowledge to the woman on how to handle the baby on or how to care for the baby and to herself. Kay for example, if possible the patient was like first time niya naborod, so it is hard for her to adjust on the settings or the new settings sa iyang life since first time niya. Like there are arising na mag-question siya sa iyang self on how to take care of the baby or unsaon niya pag alaga sa bata since new man siya as a mother, so you can give advices, or you can give proper knowledge to the new mother kung unsaon niya pag-care sa iyang anak, di ba? If you know the pregnancy history of the mother, then if singno nato ang mother was like kadamo na siya ng anak, pero the pregnancy was unplanned, so there are possibilities gapon na ang mother is maghuhuna-huna, or the mother will think about the current setting niya, like if it was unplanned tungod kay because of poverty, like maghuna-huna siya, how could he feed the baby, or unsaon niya pag-alaga sa iyang anak nga ing animan nga dili man niya expect na masugad ani ana. So because of that, you can give also advices or knowledge prior on how to take care for the baby, diba? Okay, so now proceeding to the labor and birth history, it is important to gather information on the length of labor, position of the fetus, type of birth, any analgesia or anesthesia used, problem during labor such as fatal distress, supine hypertension syndrome, and the presence of perineal sutures. This information helps in planning for necessary procedures. Okay, so now for the infant data. The sex and weight of the infant, any difficulty at birth such as the need for resuscitation, plans to breastfeed or formula feed, and any congenital anomalies present are the major facts to be obtained. This information help in planning care for the infant and promoting bonding with the parents. So next is the postpartum course. Ask about a woman's general health, her activity level since the birth, a description of Lucia, and the presence of perineal, abdominal, or breast pain, difficulty with elimination, success with the infant feeding, and response of her support person to parenting. This information helps in planning what anticipatory guidance will be needed for the home care. And after doing that, we're going to proceed to the laboratory data. Women routinely have their hemoglobin and hematocrit level measured 12 to 24 hours after birth to determine whether blood loss at birth has left them anemic. If the hemoglobin finding is lower than 10 grams per 100 milliliter, supplementary iron is usually prescribed. Take note of the laboratory reports of a postpartum woman and make certain that any abnormal findings such as low hemoglobin is brought to the attention of the woman's physician or nurse midwife. The responsibility of being a new mother coupled with additional burden of an undetected low hemoglobin level can severely tax a woman's energy levels. If a woman required catheterization during labor or had a urinary tract infection during pregnancy, a urinalysis or urine culture may be ordered in the postpartum period. Obtain a urine specimen with a clean catch technique using a sterile cotton ball tucked in the vaginal introitus to prevent Lucia from contaminating the specimen. In some women, it may be necessary to obtain a specimen by urine or by urinary catheterization to rule out urinary infection. Okay, so after obtaining the laboratory data, we're going to proceed to the physical assessment. During early labor, a woman is given fairly complete physical examination during the immediate postpartum period. Therefore, repetition of a complete examination is not necessary. Crucial assessment examining particular aspect of health, such as an estimation of nutrition and fluid state, energy level, presence or absence of pain, breast health, fundal height and consistency, Lucia amount and character, perineal integrity, and circulatory adequacy are required. Why do we need to have physical assessment to a woman or to the mother? We need to do it so that we can understand the adequacy of the woman and the state of the woman. If there is no complications or complication in his physical aspect. So that's why we need to have the physical assessment of the woman. So in physical assessment, we have this general appearance. A woman's general appearance in the postpartum period reveals a great deal about her energy level, her self-esteem, and whether she is moving in to the taking hold phase of recovery. Before beginning assessment, ask a woman to void so that she has an empty bladder. Observe how much energy she used when reaching for her robe or walking to the bathroom. Does she struggle or move listlessly, or does she accomplish this task quickly? Observe for a cringing expression or hand pressure against her abdomen that suggests pain on movement. Observe whether she has combed her hair, applied makeup, and put on her own clothes or an agency gown. Many women chose to sleep in an agency gown to prevent luscious stains on their own clothing. But a woman who is pleased with herself, her pregnancy, and her birth experience is usually anxious to wear her own cloth and fuse with her appearance within an hour after birth. A woman who is extremely exhausted or depressed probably will not bother with her appearance. This way, keep in mind that a woman whose labor processed so rapidly that she came to a healthcare agency as an emergency admission may not have time to pack a comb and brush or her own clothing. Cultural variation also affect appearance and actions. In the United States, the postpartum period is generally regarded as time of wellness. Early ambulation and eating a varied diet are encouraged. In other cultures, the period after birth may be regarded primarily as a time of rest. Cultural differences include restricting certain foods, reducing activity levels, or both. Taboos and rituals are not uncommon. Assessing women in postpartum period for cultural variation of these types is important because such variation explain why a woman might be reluctant to ambulate or why she leaves a lunch of food she views as unacceptable uneaten although she said she was hungry. So after the general appearance, we're going to proceed to the hair assessment. Palpate the woman's hair to determine its firmness and strength. Whenever a diet is deficient in nutrients, hair becomes listless and stringy. A woman who had good nutritional intake during pregnancy has a firm, crisp hair. Many women begin to lose a quantity of hair in the postpartum period. This is because during pregnancy, metabolism was increased and hair growth was rapid, so many hair reaches maturity at the same time. As the woman's body returns to a normal metabolism level, this hair is lost. So when this happens, we need to reassure a woman that hair loss is not a sign of illness, but just another aspect of return to her pre-pregnant state. Okay, after the hair assessment, we're going to proceed to the face. Assess the woman's face for evidence of edema such as puffy eyelids or a prominent fold of tissue inferior to the lower eyelid. Normally, this is negligible. However, in a woman who had pregnancy-induced hypertension and accumulated excessive fluid, it may be evident. It is also will become evident in a woman who is developing postpartum pregnancy-induced hypertension. Although this condition is rare, facial edema is most apparent early in the morning if a woman has been lying supine with her head level during the night. Okay, after the face assessment, we're going to the eye. Inspect the color and texture of the inner conjunctiva. If a woman is dehydrated, the area appears dry. A woman who is anemic from poor pregnancy nutrition or excessive blood loss at birth has pale conjunctiva. Be alert to possible variation because of skin color. However, the conjunctiva always appears lightly shaded in fair-skinned women. Dark-skinned women may have a ruddy conjunctiva appearance even with anemia. Check the hemoglobin level of any woman with paler than usual conjunctiva to determine whether anemia is present. So now we're going to proceed to the breast. Breast tissue increase in size as breast milk forms. So advise the woman to buy a nursing bra for the postpartum period that is 1 to 2 size larger than her pregnancy size to allow for this increase. Properly fitted, a bra should fit firmly and snuggle. The straps of a bra should not leave erythematic marks on a woman's shoulder. So a bra that was adequate during pregnancy may no longer be adequate by the second or third postpartum day. Use of bra supports breast tissue that feels heavy because of increased fluid accumulation and aids comfort. So that is why we need to advise a pregnant a mother to buy a nursing bra that is 1 to 2 size larger than her pregnancy size. Kay mauna ang adequate para sa iya. So next, we're going to proceed to how to assess the breast. So to assess the breast, ask a woman to remove her bra and cover her breast with a towel or folded sheet to protect modesty. Ask her to raise her hand over her head and then tuck them under her head because this stretches and thins breast tissue. Inspect and then palpate for the breast size, shape, and color. So breast tissue should feel soft on palpation on the first and second postpartum day. On the third day, it should begin to feel firm and warm. On the third or fourth day, breasts appear large and reddened with taut shiny skin. On palpation, they feel hard and tense and are painful. Normally, engorgement causes the entire breast to feel warm or appear reddened. If only one portion of breast is warm or reddened, mastitis or inflammation or possible infection of gland or milk ducts is suggested. Then occasionally, a firm nodule is detected on palpation. Usually, this is only a temporary black milk duct or milk contained in a gland that is not flowing forward to the nipple. However, the location of the nodule should be noted and reported to the woman's physician or nurse midwife so that it can be assessed before discharge from the hospital. Such blocking of breast milk usually is relieved by the infant's sucking. Nevertheless, any nodule needs reassessment because a fibrocystic or malignant growth unrelated to the pregnancy could be present. Note whether the breast nipples are normally erect and not inverted. Assess for any cracks, fissures, or the presence of caked milk. Avoid squeezing the nipples because this can be painful. Unnecessary nipple manipulation also may increase the risk of mastitis by providing a portal for infection. Okay, so after the breast assessment, we're going to proceed to the uterus and do the uterine assessment. To do this, we need to position the woman supine so that the height of the uterus is not influenced by an elevated position. Observe her abdomen for contour to detect distension and for the appearance of striae or diastasis. If a diastasis is present, it is a slightly indented, possibly bluish tinged groove in the middle line of the abdomen. Measure the width and the length by finger breadths. Then palpate the fundus of the uterus by placing one hand on the base of the uterus just above the symphysis pubis and the other at the umbilicus. Then press in and downward with the hand at the umbilicus until you bump against a firm globular mass in the abdomen, which is the uterine fundus. Then after the palpation, we're going to assess the consistency. If it is firm, soft, or budgy, the location, and the height. For the first hour after birth, the height of the fundus is at the umbilicus or even slightly above it. It is decreased 1 finger breadth in size daily. Measure the height in finger breadths such as 2 finger breadths down umbilicus or 2 cm beneath the umbilicus. Although this measurement seems less scientific than a measurement of the height of the uterus from the pubis might be, it is the most useful measurement because it shows the gradual decline in size or distance from the umbilicus. And remember, never palpate a uterus without supporting the lower segment because the uterus potentially could invert if not stabilized, resulting in a massive hemorrhage. Then palpation of a fundus should not cause pain as long as the action is done gently. If the uterus is not firm on palpation, massage it gently with the examining hand. This usually causes the uterus to contract and become firm immediately. Use a gentle rotating motion, never a hard or forceful touch, so that you do not cause pain or cause the uterus to expend excess energy in contracting. If the uterine fundus does not grow firm with the massage, extreme atony, possibly retained placenta fragments, or an excess amount of blood loss may be occurring. Notify the woman's physician or nurse midwife Then administer PRN oxytocin as ordered. In addition, placing the woman infant at breast will cause endogenous release of oxytocin and achieve the same effect as oxytocin administration. If massage appears ineffective, a clot may be present in the cavity of the uterus. The clot may be expressed from the uterus by gentle pressure on the fundus, but only after the uterus has been massaged. If the uterus is totally relaxed, fundal pressure could cause inversion of the uterus, an extremely serious complication that leads to rapid hemorrhage. Another reason the uterus may not be well contracted is the rapidly filing bladder is preventing contraction. If contraction remains inadequate, a uterine ultrasound may be ordered to help detect any abnormalities. A woman who received no oxytocin after birth to help her uterus contract is at greater risk for poor uterine contraction than is a woman who did receive this. If no oxytocin was given, assess the woman's uterine fundus every 10 to 15 minutes immediately after birth to evaluate and assess the fundus to contract should it become soft or relaxed. Once the first hour after birth has passed, a woman's uterus may be evaluated for height and consistency less frequently, depending on institutional policy. By the 9th or 10th day after delivery, the uterus will have become so small it is no longer palpable above symphysis pubis. So, after assessing the uterine or the uterus, we're going to proceed to assessing the lucia. A woman can expect to have lucia for 2 to 6 weeks. Characteristics of normal lucia and the change in pattern from red to pink to white. During the first hour after birth, when the fundus is checked every 15 minutes, also remove the mother's perineal pad and evaluate lucia's characteristic or the lucia character, amount, color. Is it rubra, serosa, or alba? Odor and presence of any clots. Be certain that the pad is not adhering to perineal stitches before removing it. When you ask a woman to turn so you can inspect her perineum, be sure to check under her buttocks to observe any blood that may be pooling beneath her. If you observe a constant trickle of vaginal flow or a woman is sucking through a pad every 60 minutes, she is losing more than the average amount of blood. She needs to be checked by a physician or nurse midwife to be certain that there is no cervical or vaginal tear causing excessive bleeding. While a woman is at the healthcare facility, inspect her lucia discharge once every 15 minutes for the first hour. Then, according to the institution's policy, make certain a woman understanding that she must wash her hands after handling pads and must use only her own personal care equipment so that she does not contract or spread infection. Demonstrate good role modeling for hand washing and equipment use. Encourage a woman to change perineal pads frequently as she begins self-care because lucia is an excellent medium for bacterial growth that could spread through the vagina to the uterus. The presence of constantly wet pads against an episiotomy suture line also slows healing. Changing pads frequently is not a problem for a woman while she is at the healthcare facility. But if she is trying to save money, she may try to conserve on the number of pads she uses at home. Be certain she knows not to use tampons until after she returns for her postpartum checkup to diminish the risk of infection and toxic shock syndrome. Ensure that women know the criteria for judging the amount and type of normal lucia so they can do this accurately. So after assessing the lucia or while evaluating the lucia, we need to also inspect the perineum. Ask a woman to turn on her side into a Sims position with her back toward you. If a midline episiotomy was performed, position the mother on either side. If a mediolateral incision is present, turning her so that the incision is on the bottom buttock often causes less pain and offers better visibility. Gently lift the upper buttock and inspect the perineum. Observe for ecchymosis, hematoma, erythema, edema, intactness, and presence of drainage or bleeding from any episiotomy stitches. Episiotomy is usually 1 or 2 inches long. However, if a laceration was involved, stitches may extend from the vagina back to the rectum. Rarely, they extend forward toward the urethra. An episiotomy incision is usually fused or edges sealed. By 24 hours after birth, if it is a midline insertion, it may be almost invisible because the perineal fold obscures it. A hematoma or blood-filled protruding sphere could be present. If surface capillaries were broken during the pressure of birth, this should be noted as a potential complication. If there is clotted lucia along the incision line, review postpartum perineal care so that this does not continue to core. Before discharge, teach a woman who has episiotomy stitches how to lay on her back and view her perineum with a handheld mirror so that once a day while at home, she can inspect her perineum for redness, sloughing, or sutures, pus formation, or drainage at the suture line. After perineal assessment, assess the rectal area for the presence of hemorrhoids. If any are present, document their number, appearance, and size in symmetry. That should be all of my report. Thank you.